I would like to start by expressing my gratitude and sense of privilege at having been invited to be here. My thanks to Dr. Venkatesh, Dr. Naveen, and other members of the organizing committee. I'm glad I'm here because I've learned a lot in the 3 lectures that I've listened to so far from Naveen, Annapurna, and Pranesh. And I realized what could be the abbreviation to describe me. As Venkatesh said, as a teacher these days in 2024, and the only thing which occurred to me was mad, miserably antiquated and dumb. When you take the requirements of Gen Z, you may well ask, why are you here? I am nowhere close to Gen Z. Technically, I belong to the baby bloomers. But if you ask me, educationally, I belong to the dinosaur era because some of my classmates are dinosaurs. So long, long ago. And the other questions which were raised was, pardon me for starting with some doubts I have. Flipped classrooms. I used to use a lot of flipped classrooms. But flipped classrooms will work only when they read the material before they come to class. I asked the first years, who are the Gen Z now, why don't you people read so that we can spend the hour usefully discussing instead of repeating what is there in the books? Because they don't read textbooks these days. They read books called Pearls. Pearls in Surgery is the textbook read by postgraduates in surgery. And I'm sure there are pearls in ophthalmology also. The textbooks are outmoded. And the lady said there are too many distractions. Now, if you have too many distractions, how does a flipped class work? I don't know, Naveen, you have to tell me before I go how you make it work here. Secondly, I also felt happy when I heard that the Gen Z is also called Zoomers. I'm also Zoomer because after COVID came, everybody is a Zoomer. We have a master's in health profession education program running. Some of them are asked to be present here. It's in a hybrid mode, mostly online. But how do you know when somebody is there on Zoom or not? Because you ask a question, there is no reply. That happens in class also, even if they are present. So how do you make out in Zoom? It's on, the name is there, and sometimes the name is replaced by various abbreviations. But you don't know whether they are there or not. And the third thing is what Pranesh said, we need to teach the way the Gen Z learns. Does it also go for assessment? We need to assess the way they want, in which case the answer will be no assessment. So I am also going to suggest that at the end of my talk, that we need not have assessments. Because assessments are antiquated and we have to now move on with the Gen Z requirements. So that's where I stand. I'm a little nervous because what I came prepared for is a little different from what I am seeing. I'll spend a few minutes talking about why this current assessment is not working. And we all know it's not working. Those of us who are in the teaching line, what changes we can do within regulatory norms, because education, as you know, professional education is tightly controlled in our country by regulatory agencies. You can't change A to B without permission. And I'll tell you also what experiments we have done over the last 8 years, which has worked in our environment. And I want to share those experiences with you. You know this. It applies as much to ophthalmology as it does to surgery. If you take the regulatory guidelines, there are no clear definition of competencies. If you take the undergraduate guidelines, it's a disaster. Can any of you guess how many competencies are prescribed for 4.5 years of undergraduate education now in the NMC? Can anybody say? 2,884. Is it humanly possible to teach 2,884 competencies to undergraduates? But that's how the book comes. It comes in 3 volumes of huge size. There's also no definition of what we must know, what's desirable, and what is nice and in the periphery, which we can leave it to them to read. The TL activities are not standard. It varies from college to college. And sometimes, as you know, nowadays, the teachers exist only for biometrics. There are no real teachers in private medical colleges. And therefore, there are no teaching learning activities. Research doesn't seem to matter. I read somewhere an article by Peter Denson that the doubling time of medical knowledge in 1950 was 30 years. So you could join service, finish service and retire with what you learned in medicine still current. In 1980, it became 7 years. In 2010, it became 3.5 years. And in 2020, it's 73 days. Every 2.5 months, the medical knowledge doubles. So how do you ever keep pace with this unless you focus on self-learning and continued professional development, which is not at all emphasized in our learning, and neither it is assessed. And to go to the assessment process, this is standard. Everywhere it is the same. If you have a huge list of competencies, one long case and one short case or 2 short cases, how do you ensure competence? Does it match with the requirements? OSCE is held only in the national board. There is no OSCE for postgraduates under the National Medical Commission. Ward rounds are there in the national board. There are no ward rounds. You don't see emergencies. You don't talk about day-to-day management in the national medical, which is what is crucial for life skills after you pass. Totally neglected. If you take assessment, the classic saying about assessment is assessment promotes learning. The student will learn what is important to pass and just enough to pass. And therefore, assessment cannot be used only to test learning, but assessment also should be used as a stimulus for learning and as a continuous process to see that learning happens. For and as doesn't happen. The summative examination is an encounter between the student and the teacher over about half an hour, because we have to finish 8 to 10 postgraduates in a matter of 4 or 5 hours. So it lacks subjectivity, validity, because it's just a short encounter. There are no fixed criteria of what is required for pass, and therefore it is always norm reference. Whoever does well, all others are compared with that individual and appropriately marked. Everything which is wrong, can be wrong, is wrong with our system. It gives no feedback. When you fail, you don't know why you failed. When you pass, you're happy you're passed, but you don't know why you're passed. And your institute and your department doesn't know whether all those who pass deserve to pass and all those who fail should fail. It's not even a one-day match. It's not a test match. It's not a one-day match. It's not a T20. It's a one-case match. If the case that is allotted to you, you have not read, or somebody has not leaked the diagnosis to you, one of the assistants, you will fail. That is the state of evaluation in our system. How can we ever ensure competency if you have to work within that system? You don't expect all of them to perform equally well, do you? That is what happens in our educational system. So the first thing we have to be clear is we understand, and therefore our students understand, what is meant by competence. There is only one definition of competence: acceptable. The attributes, the requirements of certain traits which are habitually and judiciously used, which comprises of all the domains. affective domains, the skill domain, and the knowledge domain. Communication, knowledge, technical skills, reasoning, emotion, values, and reflection. How much of these we test actually in our system? We test a little bit of knowledge, a little bit of communication while they are talking to you. They don't see how you communicate with the case allotted to you. And these competencies are of three types. You have the core, which is common to all subjects. You have the soft skills, which are also should be common to all subjects. And then you have subject-specific competencies. We're not going to go into details of this. But for the assessment system to work, the term which best describes it is it should be authentic. It should be tailored for the requirement. And what does authentic mean? Authentic means the first principle is the outcome must be clear. What is it that you are looking for? What level of performance is acceptable? So the outcome must be clear. The competencies that you are required to certify must be clear. And those must be required for real life performance after you graduate. At the same time, you must also provide feedback, because the best thing which transfers learning from recent memory to remote memory is reflection, thinking about what you have learned and why you have learned and why you have not learned. Therefore, the assessment has to promote reflection. It should be frequent and regular so that you can monitor. When you monitor, you know somebody is doing well, somebody is not doing well. Those who are not doing well, you give them additional inputs by giving feedback. Therefore, assessment is transferred from being assessment of learning to assessment as learning and assessment for learning. That is the principle of assessment. It should be concordant with real life situation. It cannot be in a remote room. In a place where I went as examiner, the students are allotted cases in the ground floor and the examiners were busy with their samosas in the second floor. And after the students finishes, they'll be marched there. You don't see them examining, you don't see them talking. Anybody can talk to them, and then you make them miserable for half an hour by asking questions. And at the end of it, they think they have failed, they have passed. Those who think they have passed, they have failed. Also, it's important that these competencies that you transfer, are they permanent or not? That's why in pedagogy, you have a term called program educational objectives. That is, what remains as competency at the end of 5 years after graduation. Not at the time of exiting from the medical college, but what remains with them as lifelong skills, which you get from feedback from their, I don't like to call them consumers, but their patients, relatives, and others who have interactions with them. That we never bother in our society. We never find out how our students are doing 5 years or 10 years after they are graduated. It should also be criterion reference. That is, the minimum cutoff to pass must be defined. That can be defined only if outcomes are defined. And there must be consensus. If you leave it to individuals, there will be a lot of subjectivity, which will be influenced by their way of talking, their way of dressing, their gender, and so on and so forth, which we know always happens. It should not happen in an examination, but therefore consensus is required. From comparative markings, we should go on to criterion reference marking. You know, when you go for recruitment in the police or the army, they'll measure your chest expansion. The chest expansion has to be 2 inches. 1.9 inches, you fail. There's no moderation there. The criterion is fixed. If you have to jump 3 feet, you have to jump 3 feet. You may jump 4 feet. You don't get extra marks. But if you jump 2.5 feet and knock the barrier down, you will be sent off. It has to be criterion reference. And when can it be criterion reference? When these criteria are clear in your mind, and they'll be clear in your mind only when the outcomes are well defined. What is it that you are looking for? Just reflect for a moment, all of those teachers and the students, whether there is any criteria prescribed to define the cutoff between pass and fail in our system. You'll realize that there is no criteria because outcomes are not very clear. Having realized all this, let's see how a system was evolved in our place. I'm only going to talk about that because that's all I have experience about. The whole world has moved to competency-based education and evaluation 20 years ago. And in India, we have not even started. That is the situation of our education. We know that competencies are attributes. Attributes cannot be assessed. And therefore, you have to rewrite this in a form where they are observable and measurable. When you do that, you call them entrustable professional activities, which means after qualification, they can be entrusted with these safely. So the first step is to rewrite competencies as entrustable professional activities. I'll show you some of the competencies in our thing. One EPA can cover several competencies, but having done that, you must break the competency into sub-competency, identify appropriate tools. If it's knowledge, you can have an MCQ. But if it's communication, you can't have an MCQ. You have to have an interaction. If it is examination, you have to have bedside examination, direct observation of procedural skills. So you have to match the evaluation tool with the requirements. This is the American system. In our own India, we have defined them, the output, as the so-called mythical Indian medical graduate. I don't know whether the mythical IMG exists, but it has been defined in NMC. They have to have 5 competencies: clinician, professional, communicator, lifelong learner, leader, and member of the healthcare team. That is what the NMC has defined. But the same is also done for every other country. Only the wording is different. So it's nothing unusual that we have done by defining the IMG. Every country, what we call a clinician, in United States, it's called somebody who has medical knowledge and also can provide patient care. What we call a communicator, they say somebody who has interpersonal and communication skills. So the wording is same. Now I show you these ENTs that we have written. Took a lot of time to write that. Yeah. This is what we wrote for the master's degree in otorhinolaryngology. See the competencies, these are the listed competencies. There are 1 to 35 in ENT. Starts with gathering history and performing physical examination, and then which are the domains it's involved, knowledge, patient care, and so on. When do you start testing? Is day 1 of residency when they join. What is the level expected? I'll go into this level. What is the final level expected before they are allowed to appear for the examination, and where all do you get feedback to see their professionalism? And these words stand for supervisor, patients and relatives, undergraduates whom they teach, peer PGs for peer feedback, community, and individual. So this is for otorhinolaryngology. I'll show you ophthalmology, which is what they use. There are only 12 EPAs, but a lot of sub-competencies. But the EPAs are only 12, written by the Department of Ophthalmology, and this is the list that they use for evaluating their postgraduates. But it's not enough if you have competencies. You must rewrite them in measurable form. When you write it as a very complex competency, you cannot measure. And therefore, I'll show you an example of how sub-competencies are to be written from the so-called 8Com module book or the Attitude, Ethics and Communication books of NMC. Yeah, this is the IMG. These are the 5 competencies: clinician, leader, communicator, lifelong learner, and professional. And when you write sub-competencies, clinician, what it means, there are from 1 to 14 or 15 sub-competencies to decide whether the role of a clinician is fulfilled or not. And then you go to leader and member of the healthcare team. There are 6 sub-competencies. So don't think that ophthalmology is looking only at 12 things. When you see the sub-competencies, there will be much more detail, because that is what is required for assessing and evaluating. How do you measure competencies? You have to first define milestones. What is milestone? These are stages in learning, starting from the date of joining till the date of final examination. Milestones means along this 3-year journey, where all do you stop and be measured? So we have decided that we'll measure them at 3 monthly intervals so that we know how they are progressing. A lot of people use this Miller's pyramid for measurement, but Miller's pyramid only pertains mostly to knowledge. You start with the Miller's pyramid originally had only these 4: knows, knows how, shows how, and does. Professor Sethuraman, who was my colleague, has added one more basement to the Miller's pyramid, because nowadays they don't know, but they know where. They can Google and find out. So he has said the basement to Miller's pyramid is know where. If you know, that is the Gen Z. And when you become a professional, like Dr. Venkatesh, then there is no more measurement, is. So it is unconscious competence. That is the highest level of proficiency. That is not what we can expect in a postgraduate, is it not? That comes after years of service. So we should go up to does when we assess them. And for skills, we have this Dreyfus model, starting at the lowest, which is novice, where they do not know the skill at all, where they have to observe, and where they can perform independently, that is without supervision, that is level 4. Level 5 is expert, that is they can teach others. We don't expect residents to reach level 5 for anything, perhaps except history taking, where they can teach undergraduates. So most will stop at level 4, or very complex procedures, even level 3 may be acceptable. You have to decide for each of those 12 things listed by ophthalmology and the 30-odd sub-competencies, what is the level required at the time of graduation, what is the level required at the end of 1 year, 2 years, and at the end of 3rd year before the examination. We do this assessment at entry. We give them this EPA list, ask them to self-assess. I remember an interesting individual, one boy who had joined MD Radiology in our college in Chennai. He marked himself 5 in all. So I asked him, why have you come here if you are expert? He said, my father has got a radiology clinic. I report there all the time. I need an MD, that's why I have come. So he is joining the program at level 5. Then we asked him a few questions and he could not answer. So that was the stimulus for reflection in him to understand the gap between self-assessment and teacher assessment. So that was a stimulus for him to learn. And we assess, we used to do it 6 monthly. Now we feel 3 monthly is better. We do it 3 monthly. And then we do, and we fix levels 4 for most of these, 5 for not even one of them. 3 for very complex procedures. If they reach 3, we are happy. Once we decide competency, how frequently they have to be measured, then the whole world has moved to workplace-based assessment. So we have not moved, unfortunately. But we have to move now. Time has come. For Gen Z, we have to move because they don't like examinations at the end. So to follow Pranesh, we give them the evaluation they want. Throughout 3 into 365 days, not a one-day match at the end. You choose. If you want to assess knowledge, you have a choice. If you want to assess clinical skills, you have a choice. If you want to assess analytical skills, you have a choice. Procedural skills, you have a choice. Soft skills, communication, professionalism, you have a choice. Leadership, lifelong learner, all have got tools. Only thing you have to match it with the requirement. Then only you'll get information that is important. And if you see here, all this, every one of these skills, people have listed which method is best. All you have to do is look at this list and decide which is the best method for that and can you do it in your environment. For instance, professionalism, OSCE is not a good method. You take whether they can work in the medical system, which is the idea 360 degrees multi-source feedback is required to see whether they fit into this system, how they work with their colleagues in the department, the interns, and their senior PGs and senior residents. So these are all ready-made. All you have to do is to adopt it in your environment. When it comes to professionalism, it's a little more difficult. Because if you see a postgraduate resident in his workplace environment, if you take a 360-degree view of that, they interact with faculty, they interact with community, patients, examiners, nurses, peers, and near peers in a team. And who decides about the professionalism? The faculty. The examiner is not seeing. Examiner is busy with samosas. So, examiner is not looking at professionalism. So, although there is 360-degree observation, we take only a unidimensional view. If you have to assess professionalism, you must ask every one of them. Then only you will have a holistic picture of professionalism. And therefore, we have multi-source feedbacks. Very difficult to implement. There's a huge cultural divide between the nurses, the attenders, the ward boys, and the postgraduates. They're not willing to give feedback. So you have to assure them that it is totally confidential, anonymous, that is not going to be revealed. It's only used for improvement. It is not even used for passing or fail. Then they will give. And what type of feedback? You can't use complex feedback for this. You have to use very, very simple feedback. We ask the relatives and patients only one of these 10 questions. Is the resident showing a caring attitude? Is he respectful to you? Is he respectful to your relatives? Is their communication skills good? Do they answer your questions? Do they clarify your doubts? This is simple and only a 3-point scale. Below par, at par, or above par. That is easy to decide. If you have a 10-point, it's very difficult to decide. But they know whether it is appropriate, less than appropriate, or more than appropriate. And we take feedback from supervisors, other faculty, from patients, from relatives, from sisters, ward boys, operating room assistants, community when they go to the community, and every possible source and from their classmates. Because working together is very, very important. Teamwork, which is an important part of the Indian medical graduate. So MSF has to be done. Having done all that, you must have a system of recording it all the time. A logbook is of absolutely no use. A logbook is written by the juniors The week before, they have to be submitted by the seniors. You know that and I know that. So that is of no use. We have to have a time-stamped record of what happens every day in the ward. And that we have for an e-portfolio in our institute, where they record what they do every day. It starts with daily record of cases, special learning activities, and so on. I'll tell you all that goes into the e-portfolio. It's good for them because after that they go like Pranesh abroad and suddenly you get a letter from them saying, I need a certificate of what I have done. Previously, it was only a letter, which may or may not be believed. Now we send them the e-portfolio if they give permission. So there is a 3-year record of what they have done. So there is lasting record of scholarship, professionalism, and competency and accomplishments. All this goes into the e-portfolio. Their postings, their rotations, the procedures they have done, research, conferences, achievements, awards, critical incidents, some, let us say, giving the wrong drug or the wrong dosage is recorded confidential, available only to them and to the supervisors. Or documents substantiating about the assessments which are done on a regular basis and reflections. And I'll show you one model portfolio. This is a young lady in anesthesia. They had a case of carcinoma of the colon posted. And she says, this is a carcinoma, these are the findings. Hypoalbuminemia was there, and this I did this, I reserved blood and all that. And the supervisor asks, this is the feedback. As soon as she records, within a few days, the supervisor asks, what is the significance of albumin in this case? Why are you so much bothered about albumin? And then the candidate looks up and answers why albumin is important in that particular case. This is how feedback is given, and this is how reflection is recorded. This is another such patient. A recording and then the feedback. What was the effect of repeated attempts on the systolic hypertension? Patient with systolic hypertension, control comes, and during intubation, wide fluctuation. So normally you will forget that because there's somebody senior to help you to manage. But when it is asked, why did you get wide fluctuations? How was it managed? How else you could have avoided that? That promotes reflective learning. So that becomes lasting. Next time they have a case, they will remember what they learned. This won't happen in a logbook because these will not be recorded in a logbook. It has a lot of use. We find it's very, very useful. It assesses learning issues and therefore you can give feedback. Those who have learning issues, we can detect early and take corrective steps instead of allowing them to progress over 3 years. We can all the time see whether learning meets the required standard of milestones at that level. You can promote reflection, give feedback on strengths. Sometimes good to say very good, excellent. That itself promotes additional efforts from them. And then assessment from becoming assessment of learning becomes assessment as and for learning, which is the purpose of assessment. Can we use it for summative examination? As of now, no, because the regulator doesn't permit. But everywhere else in the world, they are used for assessment because that's a lasting record. Therefore, what do we require? And this is for the Gen Z. If you have workplace-based learning and assessment tailored to the needs of measuring that competency, done by several people, not one person, so that objectivity is there, done regularly over a 3-year period, and recorded for everybody to see, feedback provided, reflection is there, there is, in my mind, no need for summative examination. Because that summative examination, as it is carried out now, is worse than bogus. We can replace it if the regulator agrees. But the regulator will not agree because they have their own territory to protect. But that is what we should be heading towards if we are really interested in teaching competencies and assessing competencies. There are lots of problems. I had a lot of slides. I took them back from Naveen and hid all these slides because I don't want to leave you with a negative message of what are the issues we face. We took 2 years to convince everybody from 2014 to 2016 to get all faculty to believe, to get all heads to write the EPAs. It took 2 years. And then it took another 2 years to convince people to give multi-source feedback and tell them that it is not going to damage the career. There are lots of issues. How to upload photographs, whether space, then we had to have an e-portfolio of our own. There's a lot of benefits, and these are my last slides. There is no other method of measuring competency if you want to measure competency, other than recording them, making them known to the students and to the faculty, not only to the faculty, make them aware of where their progress should be in the milestone of travel from 0 to end of 3 years, and implement it even for formative purposes, so that before the summative examination, they have reached a particular level, and then we leave in God's hands for the regulator to come around. Thank you very much.